Hi everybody, I am Dr. Rohit Punga, Professor of Oral and Maxillofacial Surgery at Faculty of Dental Sciences, SGT University, and I shall be talking about the inferior alveolar nerve block to you today. The inferior alveolar nerve block is one of the most important and challenging techniques in the field of dentistry. But if you're able to master this technique, you shall be able to perform a lot of dentistry absolutely pain-free in the mandible. So let's go ahead and look at this technique of inferior alveolar nerve block with me. This is the mandible, and for the purpose of demonstration, we have attached a sheet of wax here for the pterygomandibular raphe. There are three important landmarks for the administration of inferior alveolar nerve block. The first being the coronoid notch, which is at the deepest portion of the anterior border of ramus. The second is the pterygomandibular raphe, which is a muscular structure which is composed of the buccinator laterally and the superior constrictor medially. The third important landmark for the inferior alveolar nerve block is the pterygomandibular space, which is composed of the boundaries laterally, the medial aspect of ramus, medially, the medial pterygoid muscle, superiorly, the lateral pterygoid muscle, anteromedially, the pterygomandibular raphe, and inferiorly, the inferior border of the mandible. So, keeping in mind these three important landmarks, that's the coronoid notch, the pterygomandibular raphe, as well as the pterygomandibular space, we now are aware that we have to give our block in this space. The second important thing to understand in nerve block is that what is the target area of our needle tip when we want to administer this nerve block. For that, I would just rotate the mandible and show you this particular region. This is the mandibular foramen, which is protected by a lingual spur of bone, which is known as the lingula. The inferior alveolar nerve, which is a branch of the posterior division of the mandibular nerve, descends down on the medial aspect of the condyle and the ramus and enters this foramen. It then supplies all the teeth of the mandible. To block the nerve, we have to take our needle tip as close as possible to this region and administer the solution here. This mandibular foramen can also be located extraorally by assessing the width of the mandible. Usually, the location of the mandibular foramen is at the junction of the anterior 2/3 and the posterior 1/3. So, having an approximation of this landmark is very important because this is the target area, that is on the medial aspect, the mandibular foramen is your target area, and as the nerve enters this, the nerve is to be blocked before it enters this foramen so that the solution can be deposited around the vicinity of the nerve. Once the nerve enters this mandibular body, after that you will not be able to block this nerve. Therefore, this target area has to be assessed by certain areas of insertion. The area of insertion is the next important thing to be understood. The area of insertion or the point of insertion is the point at which you will penetrate the soft tissue and enter the needle inside the soft tissue. Now, in this block, this important area of insertion of the soft tissue is located lateral to the pterygomandibular raphe. To pinpoint the correct area, you have to draw two imaginary lines, the first being a line from the coronoid notch towards the pterygomandibular raphe. This line is roughly 6 to 10 mm above the mandibular occlusal plane. So, you can reconfirm once you place your thumb into the coronoid notch. This line can be drawn by bisecting the fingernail of the thumb placed in the coronoid notch, thereby depicting the deepest portion of the coronoid notch. This is roughly 6 to 10 mm higher than the mandibular occlusal plane and represents the height of this injection. On this line, you will take the distance from the coronoid notch 3/4 towards the pterygomandibular raphe. So, if this is the total distance from the coronoid notch to the pterygomandibular raphe, you take roughly this much. At this point, you will enter the tissue and this will be treated as your point of insertion. It is important to treat this area as your point of insertion because this will most predictably take you towards the target area. Now, let's get to the technique. So, you ask the patient to open the mandible wide. By opening the mandible wide, all the landmarks are shifted anteriorly and become easy to palpate. So, you can place your thumb in the anterior border of the ramus, identify the deepest portion, that is the coronoid notch, bisect the fingernail and draw this imaginary line towards the pterygomandibular raphe, and on this take 3/4 the distance and approach from the opposite side premolar region. When you come from here, you will realize that approximately 22 to 25 mm of needle will get inserted into the soft tissue before it hits the bone on the medial aspect of the ramus and goes to the target area. Roughly 1.2 to 1.5 ml of solution then needs to be deposited after aspiration in two planes. The aspiration in two planes should always be performed with a single hand, and then inject roughly 1.5 ml of solution into the target area. While withdrawing, if you withdraw half the needle and inject another 0.5 ml, this maneuver will also successfully place the lingual nerve block, because the lingual nerve is parallel and slightly anterior to the inferior alveolar nerve block. So by doing this maneuver, you complete the inferior alveolar nerve block as well as lingual nerve block here.